Hi everyone, welcome to today's event, Quarter 4 Safe Everyday event. My name is Tammy Buggace from the Quality and Patient Safety team. We've got two talks for you today. The first talk being from the Community Learning Disability and Autism team. We've got Shelley Taylor, one of the specialist nurses, and Stephen Taylor, one of the support workers, going to talk to you about the updates to the hospital passport. And then later on we've got a chat from MedPro, our HSE insurers, and I'll introduce them afterwards. Okay.
Thank you.
Thank you. Hiya, so I'm Shelley Taylor, I'm the Community Learning Disability nurse, and we're here to talk about the hospital passport. So,
Yep, so the hospital passport. What is a hospital passport? It's a document to support people with learning disabilities or autism. It's a reasonable adjustment. The purpose of it is to reduce the likelihood of preventable death and to help improve the patient experience in hospital.
if you look at the evidence on LEDA and from NHS England, you'll find that health inequalities exist, and as a reasonable adjustment, this helps to reduce that. So what was the before? So there was the care passport, and there was part 1 and part 2. This had replaced the original health passport, hospital passport, and it was due for review. So when we looked through it, there were a number of changes that needed, particularly around the signage, about adding additional information such as your reasonable adjustments. And then we also wanted to add the stomp and the stamp. So the stomp is stopping the medication of people with learning disability. Stamp is similar, but that works with children. So that's about monitoring medication, ensuring that people are prescribed the right medication, that it's reviewed and it's changed or it's stopped, to make sure that people with learning disability and autism are not over-medicated. We also wanted to add in the capacity law. So in the original care passport, you will have seen that we worked towards the Mental Capacity Act of the UK 2005, but we are introducing the Community Capacity Law 2020 for Guernsey, so that the hospital passport needs to reflect that law, not the mental capacity anymore. We also wanted to add the lasting power of attorney as well, because one of the things that we found in the LEDA sworn meetings is that decisions have been made for people in hospital with learning disabilities by families who have guardianship which is for finance and affairs, or they've said they've got lasting powers of attorney, but there's no information or evidence of it being activated. And there's two types of LPA. There's one for finance and affairs and one for health and welfare. So it's really important for hospital staff to know that when someone comes into hospital with a learning disability and they are not able to make decisions for themselves, and someone says, I have LPA, lasting powers of attorney, that the hospital staff are saying, can we see it? And they can also indicate this on the hospital passport that they've seen it and there's evidence there. If it's not activated, you can't use it, because that person with a learning disability has consented to someone having lasting power of attorney for health and welfare. Okay.
So, completing the hospital passport. It is 8 pages long. It's designed for families to complete with the children, with their significant others and what have you, as well as people that are receiving support through HSC. So we have also a guidance document just to assist people with this. There will be sections that perhaps people don't fully understand and what have you, so it just helps explain and yeah.
So the red section, the things you must know, those are the immediate information parts that the hospital staff will need to know when someone goes to ED or they're admitted to hospital. It's all immediate relevant information, and it's just quick information as well.
There's a yellow section. That is the things that are important for the person. So think about it from a person-centred point of view. You've got important for and important to. So the this section covers things like, sorry, I'll need to have a look a bit closer. The person's ability to see and hear, how they move around, what assistance they might need with personal care, how they use the toilet and how they sleep at night.
Okay. So this is the green part, and this is getting to know me. So that talks about the nice things about somebody. It's also important to recognise, while it's a traffic light system and the red is the need to know at the earliest point, every aspect of that is really important to that person, because if you're missing any area there, getting to know me, getting the communication, how someone communicates, you're going to break down in that therapeutic relationship. You're going to break, it's not going to be able to develop is that relationship with that patient or service user.
So, where can we get a copy from? So I'm supposed to remove that. It's currently available on the CLBAT SharePoint page. The aim is to have it available for download on the States of Guernsey website, and also we'd like to have physical copies available in the emergency department, GP surgeries, so on and so forth, so that people can just pick it up, take it away, fill it in themselves.
Yeah. And that's it.
Brilliant, thank you.
That's the end of the page.
Just, anyone got any questions?
Oh, I've always got questions about the hospital passport.
Yeah, go on, yeah.
Very keen on hospital passport. So, where are we with going electronic?
So we've got an electronic copy. We've just sent that out, and we can send you the link for that, so you've got it. We still got a couple of teething problems that we need to look at. But yeah, it's good to go. I'll be working with Jill Evans to look at getting the access to it to the emergency departments and the GPs, and the wider community as well. But yes, I can send you the link.
That's great. Yeah, I think seeing that it's going to be in the GPs, because there's a lot of people that haven't actually been ever diagnosed under the service, for example, but that might really benefit from it anyway. So I think that's really useful, because they'll be able to kind of have that relationship with them to know if they're going to benefit from it.
Yeah. Oh yeah, because I mean, if you look at, like I say, each part is really important, and if you look at your documents like your death by indifference and things like that, and your letters, the lack of communication, they're not understanding that someone needs support to eat and they need support to go to the toilet, and these things are missed, and then people have a poor experience, don't want to go back into hospital again, or they've died of a preventable death, so it really is important. And I had some feedback this week of a lady who has a hospital passport, and she's got the new hospital passport, and has recently been to hospital, and she used took the hospital passport, gave it to the hospital staff, and had a really good experience. That's really good. And it can really work. But we wanted to make it accessible for the staff, because we know the hospital staff have enough to do. They're very busy people. They don't need a very wordy document, but they need really concise information, because it's really important that they know that person. Just because someone doesn't verbally communicate doesn't mean they can't communicate.
We've used it before when I worked in day patient unit many years ago, and we used it for someone coming in from one of the schools, I think it was Lemuria or somewhere, and they sent it ahead of time, and so we knew all about them. It wasn't as complex as the one you've got now, obviously, but it was really useful. The school nurse scanned it in, emailed it to the department, and then we knew what to expect. Obviously, they came for a look around the department as well, so I thought that was really...
And those are things that we can do. We can work in different ways with families and people that are in, get our support. to you know, if there's an hospital admission, we can do planning and we can do things like that, you know, as part of the preparation of someone going into hospital. So they've got a good understanding prior to that admission. Sometimes, you know, you're not going to be able to do that if someone's going to ED. But there is that. And also if someone's been to hospital and they've been a few times, the staff get to know them, that information becomes a little bit more easier to understand. And it's also can be quite daunting if you've never interacted or worked very often with people with learning disabilities. You know, it can be very difficult of how you or unnerving of how you're going to build that relationship, you know, because sometimes people do see the learning disability and the autism prior to the person, see the person first and then see the learning disability and the autism second.
I have a question, please. In terms of GP surgeries collaboration, I am of the opinion that everything should start there because they are primary care, but I am most conscious that it's private care here. So how has that been working? How receptive have they been to this?
Well, we haven't begun that yet. That will be a work in progress. I mean, the contact we have had with GPs in our own practice when we're working with service users, you know, there's some really good GPs out there, really well engaged, really invested in that person's care. Will have a really good understanding, will, you know, be happy to have a look at the document or have a copy of the document, you know, can support in, you know, adding to the document if that's what that needs to happen. So there is some really good GPs out there. So I'm not daunted by going out and having conversations with the surgeries at all, you know, so yeah.
So Shelley, can I go back to the electronic thing again?
Yeah.
So it's available, be available electronically,
Yeah.
but is that to print off or is that to complete online?
You complete it online, yeah.
Yeah. So it's complete online and it's down. Is it then on track?
You can add it. You can so it'll come up on a PDF. So it's a fillable PDF, and then you'll be able to save it and add it to Track or Rio when we get Rio. I know that they've got something built in, but I do know once Rio is up and running, they will look at building that. But that's another conversation, and it's not. We need to get Rio in first, don't we? But I've been had positive conversations that could be a possibility.
So do you know where it's going to be on Maxims or Rio?
No, I have no idea.
Well, because we've gone to great lengths to make sure that there is a sunflower in Maxims and Rio.
Yeah.
And it would be great if it was in that.
It would be, yeah. And I'll once it's up and running and I'm able to have them conversations, I will. But I've been told it's doable. So, and I've also advised them because it used to be called Care Passport, and now we put it back to the Hospital Passport because they will do that on Rio because we wanted it to be specific for the hospital. You know, we don't want it. The Care Passport was more generic, and the thing is, we've still got people dying of preventable death, and there are still major issues. We need that document to be specific to that area. If we need another document for another area, we should create it, you know, is my view. Because I don't think diluting it will improve the health of our people in receipt of our care.
It's really good to see like the stamp stuff on there. Stomp. Having heard the session, I think it was the last time, wasn't it? And because if someone is, say, in hospital and there's no one there to advocate for them, then that's that they need to have staff on board to know what to look out for, don't they? So and that just, there should be.
You know, some of it is about it's prompts for the staff. Oh, Stomp, what's that?
Yeah.
Okay, right. What can who do we get in contact? You know, I mean, there's a list of people. There'll be a list of people out there.
Is that on the hospital passport for people to look? You know, when it says about it, does it tell you what to do?
So it's got a link to the Stomp, but it'll have a list within on each person's hospital passport. They'll have a list of people that are involved, and it'll have the you would put the role of that individual.
Yeah.
Yeah.
So Ron had his hand up.
Yeah.
Just observation really from the instance that I've read. Some people come in with their passport and the A&E actually keep their passport. So how do you prevent that from happening and making sure that the service user has his passport to wherever they are going next from A&E or the first
So
point?
the person themselves can ask for it back, and it should be given back at the point of discharge. If they're not able to do that, and they've got supporting staff, they should be prompting them to do that. Yeah, that's what I'd suggest.
It does also state it on the front of the document. This passport belongs to me, please return it when I'm discharged.
Yeah, yeah.
We do get a disconnect with this because we've had these conversations before where we've asked where they end up, and some people in ED will put them in the notes.
Yeah.
Some people don't know what to do with them and give them back to the carers,
Yeah.
and they don't always get to the ward, or if they do, they're in the back of the notes somewhere.
Yeah.
So I think it's highlighting that it exists, but I was just wondering if there was something about when everyone is completed, it is also done electronically. So it's done electronically, then printed off, so that there is something in the system whenever, if they come in an emergency, it's there.
Doesn't get
I mean,
lost.
I'd love to see barcodes or QR codes or something, but I mean, that's the way I feel.
Yeah, yeah. I mean, I do think that there's some education and some support from our team to the hospital. I think there's we need to increase that on a dialogue and make it, it's like second nature as part of someone coming into hospital, regardless of learning disability or anything like that. They're coming into hospital, what they brought with them are they've got learning disability or autism, they brought the hospital passport, and it becomes common practice. But I think that we need to make that common practice because it's reasonable adjustments. Lots of people outside of our service need reasonable adjustments. We all need adjustments when we're going into an environment that we don't feel comfortable in, that's outside of our comfort zone, like me today, I study. We all need some type of reasonable adjustment. It should be common practice and the norm, and it's making that language normal and part of our daily language, and that again comes from us educating people and making it a comfortable conversation to have and not an alien concept.
Just out of interest, do you, as part of your roles, do you go into hospital to see people when they're in, or do you not have opportunity and capacity to do that?
No, I have. I've had people on my caseload that I've worked, that I've had to do that because, when they've accessed the hospital with, and I'm able to request, having an MDT and things like that, and bring up when I think that, it needs more than just a discharge letter. I've been able to challenge things in a good way, but we also I need to understand how the hospitals work, as they need to understand how I work as well, or how our people need to be supported. The adult disability services, they would usually manage them with their management teams, but we've had input. If we need to, positive behaviour support might have input with the hospital if someone's finding it quite difficult being in that environment, and they need that. It's communications. If someone becomes agitated or frustrated or frightened and they're presenting certain behaviours that might people think is aggressive, it's because someone's probably a bit frightened, don't know what's going on, and they need that bridge or someone just to come in and provide that support through, educating the staff, and to make it a better experience for that person. Speech and language will go in, or occupational health, care coordination. So we'll have.
And do you put those positive behaviour support plans in the hospital passport, or are they too complex to do that without context around it?
They're two different documents. However, in that hospital passport, there will be reasonable adjustments and the how best to support me. what's important to me, that all that information is in there. It should, each document that a person has should reflect or complement each other, you know, to make it and you know, to provide that quality of life for that individual.
Yeah, not completed in isolation or anything.
Yeah.
Brilliant. Any other questions? No, thank you
No,
very much
all
for
right.
that. Thank you. Right, thanks. We'll just take a 5-minute coffee break while we get the online session kind of sorted out in TechWise, which we've been doing earlier. So yeah, just help yourselves to tea and coffee. Thanks. Okay, welcome back to Safe Everyday Q4 event. Next session we've got, it's online and it's from MedPro, which is the insurance company for HSC. And we've got Diane Bayliss, Head of Clinical Risk and Education, with a colleague, Vicky Miller, to talk to you about open disclosure.
So thank you for coming on to this session today. As I said, my name is Diane Bayliss. I'm Head of Clinical Risk and Education at MedPro, and I have my colleague Vicky, if you want to introduce yourself, Vicky.
Yes, I am the claims manager at MedPro. I'm responsible for any notifications that are reported on this account by states of Guernsey, so any claims, notifications, etc.
As with any educational event, we have some objectives, learning outcomes. So at the end of this session, it's really getting a better understanding and be able to define what an anticipated outcome is, have a better understanding of the importance of communication and resolution, and be able to identify some of the key steps in the disclosure duty of candour process. Next slide, thank you. So this is what we're going to be having a look at. And next slide, thank you. So to start off with, in the context of this session, we're going to be talking a lot about unanticipated outcomes. So I think it's good to just set a definition at the beginning of what we actually mean is an unanticipated outcome. And so for the purposes of this session, it's those outcomes of care that differ significantly from what is anticipated. So something you were not expecting something to happen. It can be from a medical error or sort of standard of care deviations, but we also know very much from anybody who's investigated when things go wrong, it often can come from system failures, and it includes those that are preventable and not preventable. And I think it's also very important at the very beginning to think about disclosure and apology, because throughout this session, we're really going to be talking a lot about disclosure and apology, and just really laying it out at the very beginning that it does not equal an admission of liability. So on this next slide, there are a couple of examples here. So as you can see on the left, with disclosure and apology, it's factual. It's a factual disclosure. First, admission of liability, that usually comes from an emotional kind of knee-jerk response. Something's gone wrong, so I think maybe I must have done something wrong. So really just laying it out that disclosure and apology is factual, and it is not synonymous with an admission of liability. Next slide, thanks.
Sorry, just going to add to that and chip in, sorry, from a claims perspective, because this is something that commonly is raised by several of our healthcare insureds who are concerned about insurance reporting obligations and what can they or can't they say in this situation. So as Diane said, it's not an admission of legal liability, but we do urge caution in terms of sometimes the apology can go a bit too far and start straying into the realms of potential legal causation by saying, sorry, this caused XYZ outcome or condition. So I think as long as it's kept factual and concise, then obviously it's not something we would have a problem with. And as insurers, we certainly wouldn't be trying to get in the way of doing the right thing and making, and saying an apology as appropriate.
And again, at the very beginning, I think it's useful just to take a minute to think about where you stand on duty of candour and disclosure of unanticipated outcomes. Do you think that there is value in disclosing unanticipated outcomes, or do you think that it just causes more problems and more stress, or perhaps you're not really sure which fence you're sitting on at the moment? And I just think it's just good to just check in with yourself. Next slide, thanks. Because there really has been a big paradigm shift over the last certainly 20 years. If I think back to where, because I'm a registered nurse by background, I worked in hospitals for many years, about 25 years. And, you know, back in the day, in the early 90s, there was a very, very different approach when something had gone wrong. It was, you know, it was a case of needs to know. If we think the patient needs to know about it, we might tell them. And whereas now there's been a huge paradigm shift towards a more of a safety culture and being open and honest, because that is basically what the duty of candour is all about, is about being open and honest with people when something goes wrong. Next slide, thank you. So as we're going to be talking about the duty of candour, so I'm just going to talk about some of the professional obligations around the duty of candour. Now, I know in Guernsey that you don't have any legislation at the moment, but I understand that there is something in the pipeline. So we're just going to be looking at some of the professional obligations that you do have at the moment. So next slide, please. So here we have the World Health Organization. This is a report. Again, this report here is looking at raising the need for being open and honest, a culture of safety, and, you know, telling people when something has gone wrong with their care. And on the next slide here. So if we think about the duty of candour and the background around the duty of candour, so this really was something that was highlighted in the Francis report back in 2013, following the investigation of the failings in the Mid Staffordshire hospitals. And following that report, Francis reported that he felt that there should be an organisational duty of candour in the NHS. And following that, we had the Health and Social Care Act that came into force that mandated this new duty of candour where unintended harm resulted in moderate, severe, or even death with the patient. So following that, we had the CQC introduced the mandatory duty of candour. And on the next slide. As I said before, you do not have any legislation over in Guernsey at the moment, but you're in process of developing a policy for HSC around being open and the duty of candour. And that really will mirror the guidance in the rest of the UK. So it is really highlighting the statutory. It's not going to be statutory, but it's going to be an organisational duty of candour where unintended harm had resulted in this moderate, severe harm or death with a patient, and laying out the process of reporting it, informing the patient, investigating it, and then informing the patient of what the results of the investigation. So that really is a process that you're hoping to put in place with your policy that will mirror that's happening in the rest of the UK, but it's not in legislation yet. Next slide, thank you. However, you do have for the doctors and nurses back in 2015, so we've had this professional duty of candour for about 10 years now. So again, following the CQC introducing that duty of candour, the Nursing and Midwifery Council and the General Medical Council also introduced the statutory duty of candour. We also have other organisations, other healthcare organisations have all adopted the duty of candour, and they all agree that it's something that must be disclosed to a patient when there is, it's not just serious harm, but but when something has gone wrong with their care. And it talks about being acknowledging it and providing an apology. And that's like Vicky said, you know, an apology is really about saying, I'm sorry that this has happened.
And
next
just to sorry,
Yeah.
just to add to
Yeah.
what Diane said, from an insurance kind of obligation perspective, so it's a requirement under the policy that insurers are informed where there is moderate or significant patient harm, including where there's unusual or unexpected patient death. So this is how this obligation, the duty of candour obligation, sort of dovetail in with reporting requirements under the policy. So we would typically say we're not expecting you to contact insurers in the middle of having a verbal conversation with the patient about something that went wrong. But if that does subsequently lead to either a meeting with the patient and their family, in which admissions need, you know, some apologies need to be made and an acknowledgement for what went wrong, we'd say to contact insurers in advance of that where possible. Likewise, if there is to be a letter of, you know, duty of candour letters going to be issued, and we would usually ask to see that in draft where possible, where that's in relation to anything involving moderate or severe patient harm.
So going forward, so all of those documents and, you know, the advice from the GMC, the NMC and policies, they're all pointing us in the same direction around disclosure. And it's about promoting this culture of being open and honest when something goes wrong, acknowledging what went wrong, you know, providing an explanation and providing a policy. So it's about engaging with the patients and informing them when something has gone wrong. Now we've got a little film clip that I would like to invite you just to watch. It's only about 4 minutes, but I think it's a really, really good example of how things can go well when we are open and honest with our patients.
We found out we were pregnant with Selah. Was it a week after I found out I got into law school?
I think so.
They took us in and they told us that she had DeGeorge syndrome, a chromosomal disorder. Over 2 years, they said she'd be delayed walking. She was walking, she was signing. She had a lazy eye, and so they said, you know what, let's go ahead and fix that muscle in her eye. She went into surgery and she was back in her room. She was resting comfortably. During that night, her alarms kept going up, her SATs, her oxygen levels were doing something funny. Her heart rate didn't look right to me because, you know, 2 years with a heart baby, you know all the monitors, you know, the pulse, I mean, you know everything in the room. And I said to a nurse, I said, something doesn't look right. And she said, you know what, let me get the doctor. It was a resident and he came in, it was dark in the room. He didn't turn the lights on. He didn't examine her.
He brushed it off.
And he walked out.
I decided to be closer to her. I wanted to hold her. The nurses helped me get in the bed and have Selah on top of me. And while she was in my arms, that's when she had her last seizure and slipped into a coma.
Her heart was still pumping, but her brain was gone. So after Selah passed away, we found out she had meningitis from the autopsy. We didn't want a big, huge back and forth with the hospital about pointing fingers and all that stuff, but to have a real open, honest.
Hopefully you got to hear that. I didn't hear any sound, but I think it's just a really good example of you know, the need when something goes really, really badly wrong to be able to communicate with patients and give explanations, because, you know, contrary to popular belief, when something goes wrong, patients usually want it. All the research tells us that when something goes wrong, patients really want 4 things. They want to receive an open and empathic explanation. They want an expression of regret. I'm sorry that this has happened. They want to know how similar outcomes can be prevented, and then how you're going to fix it going forward. I can always remember a story when I met a lady, I think it was at a social event at a wedding or something like that. And you know how you get talking and people will say, oh, what do you do for a living? And I explained, and people always have their stories. And this lady said to me, you know, my GP missed my breast cancer, but I didn't sue him. And I said, gosh, I'm really surprised. Can I ask you why you didn't? Because most people would these days, wouldn't they? And she said to me, you know, well, he called me in to have a meeting with him. And she said, he apologized and he was really sorry that this had happened. She said, I could tell that he didn't come to work that day to intend to make a mistake and something go badly wrong. And she said, he explained to me why this had happened to me. And then importantly, something that was very important to her is he explained what he was going to do to put things right, put something in place so it doesn't happen again to somebody else. And then she said to me, you know, I still go and see that GP because I trust him, because he was honest with me and open, and he apologized and explained everything to me. So in a sense, this GP did all of those 4 things. And I think often contrary to popular belief, it's not always about the money and suing people. So next slide, thank you. And if we look at some research around what do patients and families experience in this kind of open disclosure or duty of candor, whatever you want to call it, about being open and honest when something goes wrong. And some of the key things in this particular piece of research that they talked about patients having specific expectations. And interestingly, one of the things that they found was timeliness around the disclosure. And in this paper, they talk about the golden moment. So, and they talk about when's the best time to tell people when something has gone wrong. And the key is the sooner the better. And certainly within the first 12 to 24 hours, because the likelihood is that the patient knows that something has gone wrong. And the longer you leave it, you know, trust starts to erode and they start getting suspicious. Communication, apology and expression of regret were really high on the list of what people expected, and about being transparent and having that ongoing communication as well as having emotional support. But interestingly, one of the things that they found in this piece of research is that patients don't always perceive safety incidents the same as we do. Because I think as healthcare professionals, we almost expect something. We know things go wrong in healthcare. I think statistically about 1 in 10 people who go into hospital have some kind of adverse event. It might be just something small, not necessarily major, but it does happen really regularly. And I think we know that, but patients don't. You know, an unanticipated outcome can be the result of a known but very rare side effect of the treatment or the surgery, and that it's not necessarily error or negligence, and patients don't always hold that same kind of knowledge. And next slide, thank you. And again, this is another piece of research that again is looking at. So this is one that was specifically from the UK, and again looking at patients and families, but also including staff who've been affected by safety incidents. And some of the key recommendations that came out of this piece of research that was just published earlier this year, I think one of the things that I wanted to highlight out of this is about overcoming culturally ingrained fears of litigation. And I think that's very much one of the biggest barriers about moving forward with, you know, improving that culture, is because people are still afraid of litigation. Next slide, please. So now I'm going to just talk about some of the principles of duty of candour. So first of all, we have 10 principles here. So first of all, we have acknowledgement. So what we do to the very beginning, acknowledge the event. So acknowledge what has happened and the impact that it has happened on the patient or their family. Secondly, truthfulness, timeliness, and clarity of communication. Again, those are really important. Truthfulness, stick to the facts. It's very early in something in the there's been no investigation, so you won't have all the details. So really, this is the time to be absolutely just sticking to the facts. Don't start thinking, well, we think this might have happened. Absolutely, just stick to the facts at this point. Timeliness, as I said before, ideally within the first 24 to 48 hours, they need to have that conversation with the patient. And then clarity of communication. So avoid medical jargon. I think we're terrible as healthcare professionals with our acronyms and jargon. So really just make sure that the patient has an understanding of what has happened. Thirdly, apology. I am sorry that this has happened, okay? An expression of regret. Recognizing patient carer expectations. So put yourself in their shoes. If this has happened to you, what would you expect to happen? Okay. Staff support. I think it's really important, something that might get overlooked. Obviously, we're going to be providing support for the patient and their family, but what about the staff members that have been involved in that event? It can be absolutely devastating to the healthcare professional or a doctor. I know I had a conversation with, he was a gynecologist not long ago, and I was just talking to him about, he'd had a couple of big claims and it had had such a huge impact on him. He was absolutely devastated that something had gone wrong with his patient's care. And he shared with me that he'd had to take a couple of months off work. So I don't think we should underestimate the impact that it has on the members of staff and the doctors and the nurses. So next we have risk management and systems improvement. So this should be part of open disclosure. Duty of candour should be part of your risk management and systems improvement procedures. Multidisciplinary responsibility. We don't work in isolation. We work in multidisciplinary teams. So duty of candour should have a multidisciplinary approach. Clinical governance. Again, duty of candour should form part of clinical governance. Confidentiality, I think, goes without saying, doesn't it? Obviously confidentiality for the patient and their family, but also for those staff members that might have been involved. And then lastly, continuity of care. So telling the patient how you're going to look after them moving forward. So those are the 10 principles that really envisage everything around duty of candour. So next slide, please. So I'm just going to, so the expectation gap. So studies suggest that the gap exists from what healthcare professionals or clinicians and what the patient's views are around what is appropriate disclosure. So we're just going to spend a little time looking at some of these gaps now. So next slide, please. So I think we can all agree on what full disclosure includes. So full disclosure of all harmful events, as we've talked about then, acknowledging, providing an explanation, and how the event will be mitigated. But I think this is a really interesting study that was taken. It's a one that was done in the United States. So just over 2,500 consultants. So they were all given the same scenarios depicting serious events that had happened, and were asked what they would disclose to the patient. Interestingly, 56%, so just over half, would only partially disclose. So basically they would choose their words carefully. 42%, so just under half, would fully disclose the whole error, but 3% would provide no disclosure whatsoever. So I just think this is really interesting, that it shows that actually we've still got quite a way to go, haven't we? So next slide, please. So I just would like to invite you to think about what would prevent someone from disclosing an unanticipated outcome. You know, I said before that there are gaps, and I think there are also a lot of barriers, and research really demonstrates that while we desire transparency and we want to be open and honest and full disclosure, these attitudes are not always translated into practice, because although on one hand we might know what we should do, but it doesn't always translate into practice. So next slide, please. So the Journal of Patient Safety talk about barriers to disclosure. And so we're just going to look at these barriers over the next couple of slides. So next slide, please. So they talk about intrapersonal barriers. So these are my barriers. So what are my barriers to being open and honest when something goes wrong? It could be that I don't really know that what my professional organization, what the guidance is. Okay, so perhaps I'm a nurse from another part of the world or another part of Europe coming to work in Guernsey, and I don't know what the Nursing and Midwifery Council say around duty of candour. And then that's a possibility, because you probably do have lots of nurses coming from, and doctors coming from other areas. Things like emergence of defensive coping strategies. So that's my unconscious psychological barriers. So for example, I might think, you know, I've got to go and tell this patient that something has gone wrong with their care, and I don't think I can cope with that. That's going to cause me too much stress. And also, I might not know what the professional guidance says. I haven't read the policies, so I might be thinking, I can't do that, so I'm not going to do it. So that is one of the barriers. And on the next slide, we look at barriers, that intrapersonal barriers. And these interpersonal barriers are very much around communication. But again, as just to give you an example of this, perhaps there's a doctor who feels that they need to go and disclose something to a patient. So then they start thinking about, well, how is that going to, that information is going to impact on that patient? They're going to be upset. The doctor might not know what his requirements under the GMC, that it says that you must inform them. So then it might then provide hesitation, and they might decide, well, actually, I think it's better for them if they don't know. Okay. And again, if we think back in the day, that's what used to happen. You know, the doctors would decide whether you should be informed about something or not. But we now know that our professional bodies say that you must inform them. Next slide, please. So on the next slide, this slide talks about institutional barriers. Okay. Now, fortunately, hopefully there are no institutional barriers in your workplace, because, you know, a lot of work is being done to develop the policy, to encourage that culture. But not all organisations have that culture. And I can remember a few years ago, it was when I used to work with a different organisation, and myself and my colleague were doing a piece of work with a hospital it was in the British Virgin Islands, actually. And it was during COVID, so we were doing these interviews via Zoom. I don't know if you can remember COVID, where everybody just seemed to live their lives on Zoom. I was gutted, because if it hadn't been COVID, we might have got a trip to the British Virgin Islands. Anyway, so we were having these conversations with groups of staff, and one of the questions that I would ask them was, you know, if you think that you have done something wrong, would you report it to your manager? Now, I hope that if I would be asking you there, that you would all say, yes, of course, I would report it to my manager. But absolutely across the board, everybody said, absolutely not, we'd get sacked. So that was just a sure indication that the culture in that organisation was not great. Okay. One of the barriers also might be people don't know what the process is, how to report. So hence the importance of training. Next slide, please. And other barriers, some that I mentioned earlier. So societal barriers, so damage to your reputation. You know, if I report this, am I going to be splashed all over social media? Am I going to get sued? So all that concern around the legal aspect of it as well. And also, you know, lack of information around the reporting. So those are some of the barriers. So so far we've looked at why you should engage with duty of candour and be open and honest when something goes wrong, and then we looked at some of the barriers. So we're going to look now in, you know, at the actual conversation. How do you do it? Next slide, please. And as I just said before, training is really important, isn't it? So hopefully we're going to be able to cascade this training out to your staff, so everybody has a really fixed understanding about what is an unanticipated outcome and what their requirements are under duty of candour. Next slide, please. So from a practical sense when does the disclosure process begin? And there is a train of thought that thinks that actually it should begin with the informed consent process. Because if you think about it, all the patients who are coming in to hospital to have a procedure or to have some surgery or something like that, the consultant will have discussed with them and consented them for the process and discussed with them what the risks of that procedure or surgery could be. Okay, so that is a good in for the doctor to start saying, you know, can you remember when we discussed the possibility of the risks of this surgery? Well, I'm sorry to have to inform you that X has happened. Next slide, please. And as we said earlier, acknowledging the anticipated outcome. So that's a starting point for everybody. So I appreciate that not everybody is going to be involved with these serious patient safety incidents, and hopefully they are going to be a rare occasion. But you may well be involved in everyday occurrences, like an incorrect medication being given to a patient or something like that. So acknowledging the anticipated outcome. So for example, Mrs. Sullivan, I need to inform you that this morning you received a medication that was intended for another patient. I'm sorry that this has happened. Okay, sticking to the facts. And I know you wanted to come in on this one, Vicky.
Yes, I think there can be a tendency sometimes to kind of overly apologise for something or be drawn into speculation about what may or may not have happened had these events not occurred. And that could be as a result of the patient or the family asking these questions. But again, as Diane said, it is really important to stick to the facts. And I think particularly where potentially you're attending a meeting with the family or the patient, I think it's often a good idea to have an agenda prepared in advance of that meeting to help really focus the attention on the specific items of the agenda, so that if the conversation does stray outside of those items and maybe the patient or the family references compensation, for instance, whose fault is this? What's the likely what would the outcome have been had this not happened? What would the treatment have looked like? Then you can really refocus attention back to what's in the agenda. Say this isn't the appropriate forum for this particular discussion, but they can put their any further comments about if they want compensation or whatever in writing, and they can be considered separately outside of that particular meeting. And that way everyone's clear as to what the intention is behind the meeting, and that it's not kind of going completely off piste. And because I appreciate the fact that it can be very highly charged, these situations, there can be a lot of emotions in the moment, and it can be quite stressful for all involved. And I think having an agenda just helps everybody feel that little bit more prepared. And I should also add that for quite especially difficult situations, we're always happy to advise and guide in advance of any such discussions, and we're always on hand if that would assist.
But what about if an error occurs without any harm or minimal harm to the patient? Do we still inform them? Next slide, please. And the General Medical Council, the Nursing and Midwifery Council is very clear about that we should still be informing patients about minimal or no harm events. Because at the end of the day, the facts are probably in the health record. And I had an interesting insight into this earlier this year. My husband was in hospital on a cardiology ward, and I went in to visit him one day, and he said to me, "The doctor's been and apologized to me." And I said, "Oh, really? What happened?" So he was on a monitor, so he was on bed rest. So he was having some injections, so it was Clexane or something like that to stop him getting blood clots. And he said to me, those injections that have been stabbing me with twice a day, turns out I should only have been having them once a day. So the doctor came and apologized. And he was actually very impressed that the doctor had done that, because from his point of view was that she could have just changed the prescription and he would have been none the wiser. And he would probably have been happy because, it's been changed to once a day, not twice a day. But actually, she really went up in his esteem because she came and apologized. So strangely, it is a relationship builder. And so I just thought I'd share that story with you. So it really is important, even those minimal or no harm events, our guidance, that the professional guidance is quite clear that we should still be disclosing those. Next slide, please. So saying sorry, when we went through those, the principles of open disclosure, saying sorry is high on there. So an expression of regret is the right thing to do. As we said earlier, it's not an admission of liability. I am sorry that this has happened, but it's all in how you say it, isn't it, Vicky, as well?
Yes, and I think, as I was saying earlier, this is definitely something that comes up quite often with many of our insureds saying, look, I'm about to have this conversation. What can we or can't we say? And we're not there to kind of put words together for you. We can give some general guidance. I think it can often seem quite insincere, for example, if people want to prepare a bit of a script, and I've been asked this before, can we just write some things down? And whilst it's one thing making a few notes, and obviously, like I say, having an agenda to sort of guide the discussion, there's a risk of it being sort of insincere or sort of forced by having a script. So I think it's just important to obviously meet beforehand, before you meet with the family, have all the clinicians in the room and just to discuss what you're going to be going through, what you're going to be covering, and then just keep the apology, obviously keep it concise, keep it clear, and keep it factual. So that would be my advice.
Who should be involved? So who should be leading this conversation? And I would say it was the senior clinician. So as a rule of thumb, it would be the consultant, because certainly they'd be the person that would be answering questions, you know, who can answer the clinical questions. We would also suggest that they obviously don't go in on their own to have this conversation. Take one of the nurses with them, who can may perhaps provide support to the patient. You remember that emotional support, and who can also support with any other questions in the process. Next slide. So we already talked about timing earlier. So really it's about as soon as practicable. So as soon as you are aware that you've had those discussions, that the patient needs to be involved, as soon as all the basic facts are known, okay? As I said earlier, you're not going to know all the facts straight from the outset, but just the basic facts. And so the sooner the better is good, and certainly within the first 24 to 48 hours. Next slide. And where you do it, obviously somewhere quiet, that you're not going to be disturbed, so that you know that it's you can have that conversation confidentially with the patient. The next slide. So the disclosure conversation, as we've said a couple of times, and as Vicky said earlier, it's about providing the concise facts in layman's terms, okay? Be empathetic, offering that apology. Did you want to comment on there, Vicky?
Just a couple of small points, really. I think it's always good to have somebody there as kind of a note taker, so somebody that's not directly involved, obviously, in the patient's care, and who's not having that direct conversation, and obviously can be identified within the group as to, you know, what their role is at the start of the meeting, but really to take minutes and then to share those minutes following the meeting. I think, again, just to kind of, it's so everybody feels heard, and that if there is any confusion or any further follow-up questions that the patient or the family may have, they can then be addressed. So I think that's quite a useful to have somebody within that role.
Great, thank you. Next slide. So you might have heard this expression about closing the loop. So it's about making sure that you've had that conversation and that the information has been understood. And, you know, one of the things that we would encourage people is to perhaps question, you know, typically, well, we've given you a lot of information, Mrs. Jones. Do you want to just, so I know that you've understood what we've told you today, just tell me what you understand from our conversation, or what you're going to tell your family when they come in today. So again, just making sure that the information has been conveyed and they understand as well. Next slide, thank you. So communication is absolutely a key part in this whole process, yeah? So I'm just going to talk quickly about communication in the next few slides. So this slide here is very, very busy, isn't it? And I think that's the whole point in it, because in hospital, in a healthcare setting, there's not just one person looking after that patient. Very often it's lots and lots of different departments are involved, and that's the whole point in this slide. And I said earlier that it should have a multidisciplinary approach. So dealing with duty of candor, having those disclosure conversations should also have a multidisciplinary approach. And next slide, thank you. So some of you may be familiar with this slide. You might have seen this before. This is a well-known piece of research for Professor Mehrabian, who's from the University of California. And in his research, he concluded that people make assumptions and perceptions about us from the tone, our body language, and the tone of voice. So basically, it's not about what you say, it's how you say it. Yeah, it's just as important. And if I just think back to that story of that lady with the breast cancer, who, you know, whose GP obviously had really good communication skills, because he was able to really relay, you know, his apology to her, probably using good body language and tone of voice. You might have heard of the expression of somebody saying, you might forget what they say, but you never forget how they make you feel. So feelings really do come into it. So I think that's a really important part of communicating, and certainly, you know, communicating that empathy to the patient when we're dealing with situations like this. And next slide. So as I said before, communication, it really is the process. So we've got the sender, we've got the message, and the patient's receiving it. And we need to get that feedback just to make sure that we've closed that loop, and to make sure that all that information has been conveyed. And next slide, thank you. Yeah, so the message is only successful when the sender and the receiver perceive it in the same way. Next slide. So I can't convey enough the importance of good communication, because if you don't have good listening skills and good communication, you know, it really does increase the risk of litigation. We're not saying that if you do all this and you do it properly that they're not going to sue. They might still do that, but it's also about having, you know, that relationship with the patient. I was at a conference a couple of months ago. It was a healthcare risk conference, and there was a session given by a plaintiff's attorney. So these are the lawyers who represent the patients who sue us. And he was doing a session on why patients sue. And I tell you, that session was absolutely packed out. It was one of the busiest sessions I've been to. And it was just really, really important. He started by saying, right, all of his cases start with a telephone call from a patient or a family member. And it starts out off with, usually, I'm not the sort of person that wants to sue my doctor, but something has happened. Something's gone wrong with my care, or my mother, or my partner's care. We know something has happened, but nobody will talk to us. We just want answers, and nobody's giving us an explanation. Nobody's talking to us, okay? And he said 100% of the cases that they take, that is one of a key thing, okay? So having this communication, making sure that we're being open and honest, and engaging with the patients is just so vitally important. Next slide, please. So this is again, just to back that up. So this is from so Candelo are the Harvard Risk Management Foundation, and some data again from the United States, but it's a huge data set from about 59,000 clinical negligence cases. 40% of them involved communication failure. And of those that involved a communication failure, 39% of them closed with a payment. So that's just to really reinforce how important good communication skills are. Next slide. Okay, so we're nearly on the home stretch now. Just some final thoughts for you, and next slide. So when disclosing, remember, identify the facts. You're not going to have all the information at the outset. Just stick to the facts. Use a communication checklist, or some kind of checklist that Vicky was just talking about. It's okay to do that, just so that you've covered everything. Please, if you have one takeaway from this session, is please remember it's okay to say sorry. I am sorry that this has happened. Don't forget to offer support or maybe even counselling to the healthcare staff that has been involved in the event, as well as the patient. And then lastly, honour your commitment to follow up with them. You know, if you've said that you're going to, you'll get back to them with some more details, or you're going to write to them, make sure that's done. And next slide. So in summary, when it's done well, it can really reduce the impact of these unexpected outcomes. Unfortunately, we know that healthcare is risky. We know things go wrong, but done properly, that can really reduce the impacts. Yeah, having policies and procedures, make sure you're providing good training to staff, having a good standard of communication, documentation, as Vicky said earlier, you know, having another person in the room that's documenting the conversation and making sure that that is documented in the records, who was present at that meeting and what was said, and don't forget to provide emotional support. And next slide, thank you. Okay, so this session, it is a CPD accredited session. So if you wanted to get your phones and just scan the QR code, which will take you to a feedback form. And if you complete that with you and put your email address in, I'll send you a certificate. And I'll give you a few minutes there. So I don't know if we can open it up to any questions at this point.
I've seen sessions at the Patient Safety Conference a couple of times about involving families and service users, and how that often reduces the amount of litigation that happens. But I think, as you rightly said, the barriers to that are fear of having that involvement. It creates a fear of creating more litigation. So it's a bit of a cycle. How do we break that cycle?
It is a difficult one, and I think ultimately it's, you know, you never know is the answer. You know, you're never going to know who is more likely to sue as opposed to anybody else, and there can be a range of reasons for people wanting to go down a legal route. That shouldn't prevent you from doing the right thing. Offering an apology is appropriate and following the steps we discussed. That shouldn't be like the dominant thing in your minds about, am I going to get sued? Because I think it can then make the apology less sincere. It can make the process more daunting and more, you know, more anxiety inducing than it may need to be, because ultimately you don't know what somebody's going to be doing next. And I think I would say, don't let that detract you from doing the right thing, and make the apology, make sure it's documented, follow the steps that we discussed in this training. So, you know, don't over apologize, don't stray into kind of legal causation. Sorry, I caused this to happen and this could have been the outcome. Don't be hypothesizing about what could happen next, because ultimately that is something that people do latch onto. You know, you kind of overly explain something. Just try and keep it concise. And then just be as open as possible. So I think, you know, if the family do have follow-up questions, fine, invite that. But I wouldn't be thinking, oh, who else is going to read this? You know, they're going to send this to lawyers, because I think that there has to be a process that's adopted that's sort of a fair and transparent process, and that should be paramount. And ultimately, you know, if they are going to go down the legal route, then they'll probably do that anyway. And they still have to have a legal basis for bringing a claim in the first place, which is something very different, as Diane was highlighting, from the duty of candour process, you know, where you're saying something has gone wrong or something, you know, there has been an element of patient harm, but it doesn't necessarily mean that somebody's been negligent as a result of that. So I think the two are two different things, essentially.
Thank you. Can you hear this question?
Go ahead. I think so.
Well, it was more of a point, really, that I think maybe I'd not been clear when I'd emailed you, because we do have a duty of candour policy. It's just been updated, so that just to make it clear for anyone that's viewing online. And I suppose the other thing that I was thinking about, and I'm hogging questions, but about in the UK there's quite a lot of patient safety liaison officers that help with the kind of engagement. Do you see that is helpful in reducing litigation or resolving cases quicker?
I wouldn't be able to comment on whether that reduces litigation or resolving cases quicker, but I guess if that person this is a role that they're doing quite frequently, and one would hope that they have got some good communication skills, so that, you know, they would probably be more used to doing this rather than, you know, for example, a ward manager who may just do it once in a while and be unsure in the process. I think the benefits of having a named person doing it is that they would, you know, just be more proficient in their approach really, and their investigation and throughout the whole process.
No, there's nothing else from us, but I really want to say thank you very much for joining us. Sorry about the tech issues, but I think we managed all right, and we heard it all you had to say, so thank you very much. Right, thank you all. We haven't got any planned for Safe Everyday events planned for 26 yet, but we will do. We'll have quarterly sessions again, and I will get those invites out as soon as I've got the dates sorted out. But thank you all for coming. See you later.